So we are going to start the cornea part 10 and we are going to study about the interstitial keratitis. Basically, interstitial keratitis is a disease in which the cornea is affected, corneal stroma is affected, but the corneal and epithelium and endothelium are intact and they are not affected. So this is interstitial mean intermediate keratitis. So let's see what is the diseases that causes the interstitial keratitis. Interstitial keratitis is the inflammation of the corneal stroma without primarily involvement of the epithelium or endothelium. In most cases, the inflammation is thought to be an immune mediated process triggered by an appropriate antigen. So basically, it is an uh, immune mediated. So there is an immune reaction to some antigen. The term is most commonly referred to the late appearance of the feathery mid-stromal scarring with ghost vessels rather than acute presentation. So basically, it is usually present in the chronic form when the lesion has been healed. There is a lesion in the mid-stroma, feathery lesion, and there will be a ghost vessels around it. The former is typically an incidental finding. Syphilitic interstitial keratitis is the archetype, but the relative frequency of the causes varies markedly by the geographic region. There is a wide range of causes include herpes simplex, varicella zoster, and other viral infections, tuberculosis, Lyme disease, and other infection. Parasitic diseases are important cause in the areas where there are endemic sarcoidosis, Cogan syndrome, and non-infectious inflammatory condition. So, most important of the interstitial keratitis is a syphilitic keratitis. If you see a case of this interstitial keratitis, you must rule out the syphilis. Rest are the herpes simplex virus, herpes zoster virus, and tuberculosis, TB, Lyme's disease, and one of the very important is a Cogan syndrome, sarcoidosis, and other non-inflammatory conditions. So let's start it with the syphilitic interstitial keratitis. Interstitial keratitis of the syphilitic origin is usually the result of the congenital infection, though acquired syphilis can also be responsible. All patients with acute interstitial keratitis or with incidental discovery of its chronic appearance should be investigated to exclude congenital and acquired syphilis irrespective of the presence of a systemic clinical sign. There are numerous reported cases of congenital syphilis being identified for the first time in the later life on this basis. So basically, most important cause of the interstitial keratitis is syphilis. It most commonly associated with the congenital causes. It can also be associated with acquired, but it is usually associated with the congenital. The acquired is usually associated with the uveitis. Now, congenital syphilis has different systemic diseases, and acquired has difference. Acquired is when it is acquired sometimes in life, and congenital is when the it is infected through the fetus. Congenital syphilis infection of the fetus can occur across the placenta, leading to stillbirth, subclinical infection, or a range of clinical features. So it can also result in stillbirth, subclinical infection, and there are some features. So there are early systemic features, late systemic signs, and the ocular features that is associated with the congenital syphilis. Early systemic features. Early systemic features include failure to thrive, a maculopapular rash, mucosal ulcer, characteristic fissures around the lips, rages, and a range of organ involvement. So basically, in the case of early systemic feature, is basically rash. It can be any form. It can be a maculopapular rash. It can be the ulcers on the mucous membrane, mouth ulcers, or can be there will be the fissure around the lips. Now, the late systemic signs includes sensory neural deafness, saddle-shaped nasal deformity, seborrheic TBI, bulldog jaw, mandibular prominence due to maxillary underdevelopment, Hutchinson teeth, not small, widely spaced teeth, and Clunton joints, painless effusion in large joint, especially the knees. So basically, these are all the late systemic signs that appear. Most important is the Hutchinson's teeth. So Hutchinson sees in there when there is a gap between the teeth. So this is a Hutchinson scene. Saddle shaped deformity, the nasal is very flat shape. And when bulldog jaw is when there will be the mandible prominence because the maxilla is not developed. So we will see figure 7.20 A and B. So these are the systemic signs of the congenital stiffness. There is a saddle shaped nasal deformity like this. There is a separate tibiae like this, and there is a Hutchinson teeth when there is a gapping of the teeth. Ocular features. So Clanton joints is the effusion in the large joints, especially the knee. Ocular features include anterior uveitis, interstitial keratitis, dislocated or subluxated lens, cataract, optic atrophy, salt and pepper pigmentary retinopathy, and Argyll-Robertson pupil. So these are very important things that you have to remember ocular wise, is that what it causes from the anterior to posterior. Anteriorly in the cornea it causes interstitial keratitis. When it goes internally it causes anterior uveitis. When it causes more, it causes the subluxated lens. When it goes more inside it can cause optic atrophy and salt and pepper pigmentary retinopathy, and in case of the pupils it causes the Argyll-Robertson pupil. So what are the presentation of the syphilitic anterior interstitial keratitis? So this is a, you can see the salt and pepper retinopathy following congenital syphilis, syphilitic infection. So you can see that like the black dots are like the pepper and white dots are like the salt. Symptoms. The presentation of the anterior interstitial keratitis following congenital syphilis infection is usually between the ages of the 5 to 25 years of age. So it usually present when the patient is of 5 to 25 years of age. The initial symptoms are those of acute anterior uveitis with severe blurring. Involvement is bilateral in 80%, although usually not simultaneous. In acquired causes, IK is less common and is usually unilateral, typically occurring years after the age at which the disease was contracted, although it can occur as a part of syndrome of a primary infection. So the IK is usually associated with the congenital infection, and it is usually present with 5 to 25 years of age, and its involvement is usually bilateral 80% of the time. Signs. Profoundly decreased visual acuity is typical in active stage. So what will be the sign? Decreased visual acuity. Patient will present with the decreased visual acuity. Limbitis associated with deep stromal vascularization with cellular infiltration and clouding that may obscure the still perfused vessel to give the characteristic pinkish salmon patch appearance. Figure 7.22a. So we will see figure 7.22a. So this is a syphilitic interstitial keratitis, a salmon patch showing deep stromal vascularization with a clouding. So what is a salmon patch? Salmon patch is when the vessels are, so salmon patch are basically when there are perfused vessels. The vessels are very perfused and they usually appear red. But due to the overlying whitish infiltrate or whitish infiltrate and clouding, it appears, the red appears pink. So it is called salmon patch appearance. Next is a granulomatous anterior uveitis. So syphilis is associated with granulomatous anterior uveitis. After several months, the cornea begin to clear and the vessel become non-perfused, ghost vessels. So when the perfused vessels, they become non-perfused, they become ghost vessels. If the cornea later become inflamed, the vessel may refill with blood and may rarely bleed into cornea. The heel stage is characterized by ghost vessel, feathery, deep stromal scarring, and sometimes thinning, astigmatism, and band keratopathy. So basically, usually we are presented with this type of stage, heel stage, when the patient is presented with the stroma is feathery edges and there is a haze, corneal haze, as well as there is thinning, astigmatism, and band keratopathy. So we can see in the figure 0.22. So B is showing us the ghost vessels. C is showing the intrasomal corneal hemorrhage from reperfused vessels, and D is showing the typical feathery scarring. The tract of ghost vessels are clearly seen. So, what are the treatment of active syphilitic anterior interstitial keratitis is with the topical steroid and cycloplegics, as well as immediate systemic therapy under the care of a urinary or infectious disease specialist. So we give systemic treatment, but in case of topical we give steroid. I told you earlier, whenever the epithelium is intact and there is a corneal stromal lesion, then we give steroid. Now what another is case of a Cogan syndrome. Cogan syndrome, it is also causes the interstitial keratitis. Cogan syndrome is a rare systemic autoimmune vasculitis characterized by intraocular inflammation and vestibulo-auditory dysfunction, particularly neurosensory development within months of each other. So basically, the Cogan syndrome is a, a vasculitis or inflammatory lesion that affects the vestibulo-auditory system, you can say ear and balance, plus the ocular inflammation. The disease primarily occur in young adults with both sexes affected equally. Children can also be affected. Systemic features occur in 30% and may include multi-system vasculitis that can be life-threatening. Multi-specialty management is vital. So there can be systemic involvement as well, but the Cogan is usually affecting the vestibulo-auditory system. So diagnosis is ocular and inner ear symptoms are often separated by a substantial period. The acute phase may last from months to years. Susac syndrome, retinocochleocerebrovasculopathy should be considered in the differential diagnosis. So, what are the differential diagnosis of Cogan syndrome? It is a Susac syndrome. And what is a Susac syndrome? It is a RCC, retinocochleocerebral, cerebral brain, cochleo ear, and retina is affected. So, what are the vestibulo-auditory symptoms? Deafness, tinnitus, and vertigo. So, whatever is considered with the ocular symptoms are vestibular symptoms are the deafness, tinnitus, and vertigo. Ocular symptoms are redness, pain, photophobia, and blurred vision. So, any interstitial keratitis, it is affecting the cornea. So, pain, redness, and photophobia and blurred vision. And what are the ocular signs? Corneal involvement commences with a faint bilateral peripheral anterior stromal opacities. Deep opacification and corneal neovascularization, mid-stromal vascular loops that ensues often with central progression. Uveitis, scleritis, and retinal vasculitis may develop. So, ocular signs are basically in the case of a cornea, there will be the anterior peripheral stromal opacities, and that can be associated with the deep vascularization and deeper opacification. And sometimes it also involves the center of the cornea as well, but it is usually peripheral. So you can see figure 7.23 A and B. So 7.23 is an old interstitial keratitis in a Cogan syndrome. A is showing the peripheral region and B is showing the more central scarring. So what are the investigations? Investigation are the ESR, erythrocyte sedimentation rate, and C-reactive protein may be elevated and the white blood cell count may be raised. Antibodies to the inner ear antigen may be detectable. MRI may show inner ear and other abnormalities. So you have to remember that interstitial keratitis plus or vestibular auditory symptoms is with the Cogan syndrome. So what are the treatment? Treatment are the topical steroid for the keratitis with additional measure as appropriate. Systemic steroid are vestibulo-auditory symptoms require immediate treatment with 1 to 2 milligram per kg prednisolone to prevent hearing loss. Immunosuppressive therapy may also be required. Systemic steroids may also be required for scleritis or retinal vasculitis. So basically, the steroids are the mainstay treatment of the interstitial keratitis because it is an inflammatory lesion that affect the ear and the ears. So, eyes and the ears. So basically, for the eyes we give topical steroid, and for the ears we give systemic steroid. So that's it for the cornea part 10. So we will see in the next lecture. Thank you.